Okay, I'm gonna go ahead and get started. Thank you again, everybody who is joining us today. My name is Sarah. I'm a digital communications specialist at Center for Improving Value in Healthcare, or CIVHC. Specialist is a stretch, but it's the title they gave me. Today, we are excited to be talking about an evaluation CIVHC performed for Carol's Wish, which is a program, a financial navigation program through the Colorado Gynecologic Cancer Alliance, and talking about the results of that evaluation. Go ahead and hit to the next slide, Val. So today we are thrilled to be joined by two folks from the Colorado Gynecologic Cancer Alliance. Patrice is the executive director and Debbie is a financial advocate through the Carol's Wish program. We'll also be hearing from members of CIVHC's Research, Partnerships, and Innovations. We call that the RPI department. We have Darcy, who is our director of research at CIVHC, Valerie, who is our evaluation analyst, and Miga, who's our senior evaluation analyst, and they all worked very hard on this evaluation. Go ahead and jump over, Sal. So just a quick rundown of our agenda today. First, I'll just very briefly give you a quick overview of CIVHC and who we are, in case this is the first time that you're joining us for a presentation today. I will then turn it over to Patrice and Debbie to talk about Carol's Wish and the work that they do, how they came to partner with us at CIVHC. Our RPI team will talk about how they established the evaluation that we performed for Carol's Wish and the findings of the evaluation. We will then open that into a broader discussion on the impact of financial navigation services for patients and the potential impact to healthcare policy. And finally, at the end, we will open up to some Q&A from everybody else. Go ahead, Belle. First, just quickly, some quick housekeeping. All lines are muted right now, but we do want to hear from everybody. So if you have a question that comes up throughout this presentation, please feel free to just go ahead and type it into the chat box. Like I mentioned, at the end, we will have some time to open it up for a Q&A. So please just go ahead and if something pops into your head as we're going through today, put it in the chat box and we'll go through everything later. This webinar is being recorded, and the slides and the recorded presentation will be made available on CIVHC's website at a later time. So first, just quickly, who we are at CIVHC. We are a nonprofit. Our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data. We do all of that to try and improve health and healthcare for Coloradans. Our vision is that everyone will have the opportunity to be healthy and has access to equitable, affordable, and high-quality healthcare. As I mentioned, we are a nonprofit. We pride ourselves on being independent and objective. Go ahead, Val. And we serve through working with our change agents. So we work with a variety of folks throughout the healthcare landscape, but always with the consumers or patients at the center of what we do and our focus. We refer to anybody who is working to improve healthcare as a change agent. So that is an individual, community, or organizations who are working to lower costs and improve care and make Coloradans healthier. So we have worked with clinicians, we work with hospitals, government agencies, researchers, health plans, employers, and nonprofits. And this will be a great example today of some of the work that we do to support nonprofits at CIVHC. Go ahead, Val. And finally, how do we serve? We serve as the administrator of the Colorado All-Payer Claims Database, or the CIVHC. And through that work, we release public CIVHC data for people to access on our website through interactive reports and publications. We also license non-public COAPC data. And we do additional supportive services. Today, we'll be talking about some of those through our program evaluation, there we go, and research work. We also do a good deal of community engagement, provide analytic services, and do healthcare programming through palliative care work and advanced care planning. And with that, I will go ahead and turn it over to Patrice and Debbie to talk about Carol's Wish and the wonderful work that they do. So go ahead.
Thanks. Yes, I'm Patrice Hotman. I'm the Executive Director of Colorado Gynecologic Cancer Alliance. If you don't know that word, gynecologic, think of gynecologist. So we support people that have cancer of the female reproductive system and through emotional and financial support services. And through this is really a story of a new cool program we're doing and us trying to get our heads around how to measure it, of which CIVHC is part of the answer. So just to start with, to let you know, we originally, we had a cash grants program for low-income women in treatment. But the bottom line is that only does so much for folks. So we found a program that we wanted to mimic in some way, and it was out of a hospital in Grand Rapids, Michigan, and it was a proactive financial navigation. So, but first, I'm just going to lay the groundwork, a little bit of scaffolding, so you understand where we were coming from. Next slide, please. So, as you could probably guess, cancer is one of the most expensive health problems that you can have, and that ranges from everything from chemotherapy, surgery, radiation, hospitalization. It is very expensive, but in my point number 2, the uninsured are for sure a problem, but the other big piece is underinsured, which many of us are. And the problem is we don't buy our health insurance like we do our car insurance, right? When you buy your car insurance, you're like, what's going to happen if my car gets totaled? Do I need full replacement value? You make decisions based on calamity, but we don't do that in health insurance. We don't say, maybe I'll get cancer this year. You just, you kind of look at what your current status is. You look for a plan that covers your medications. It leaves a lot of us, well, and obviously premium prices are a big part of that too. So a lot of folks get minimal coverage and then life happens. So, and when life happens, that means that the cancer survivors end up having, not just for that year, the year the calamity happens, right? But this can be a financial strain, catastrophe for many years and potentially the rest of their lives. And with a cancer diagnosis also, you have the situation where not everybody gets to go through treatment and be cancer free, right? Lots of people have recurrence. So there's ongoing medical situations. Next slide, please. So the bottom line is we're talking about what's called financial toxicity, which is when the cost of care can prevent you from getting better. And it's considered an adverse, this is from a Journal of American Medicine article, obviously, I should note, but it's considered an adverse event for patients. And I think that the second thing that's really important to understand is just how huge this problem is, which again, if you do any reading of the paper, I'm sure you know, but it's such a big problem that at least half of the patients are going to be impacted by financial hardship. And again, this isn't talking about a 1-year financial hardship, right? That financial burdens associated with cancer care really increase financial strain on a family. So a lot of folks, if you're just getting by, I don't know if you've ever seen the reporting on that Fed survey, which said the average American household couldn't handle a $400 out-of-pocket unexpected cost. Well, you can imagine when you get cancer diagnosis, it is that, but a lot more. So what happens with that is that it really impacts equal access to care, because people start self-editing themselves out of the process because they're trying to save money. And one of the things that we have definitely seen, for example, is people just saying, well, maybe if I take this medication every other day, then it will last longer. And so they start doing things that impact the quality of care and therefore increases mortality. So I know that everybody on this call, and I think every American doesn't believe, believes that everyone should have equal access to care, but we all know we live in a system where that just doesn't happen. And so that's what we were trying to take on with this program. Next slide, please. So what we did is, again, copy this program that was meant for a hospital setting where they control more of the levers of cost. But we, as a patient advocacy group, wanted to do the same, do the kind of proactive help where we can. So we're working in some physicians' offices where they actually have us as part of their paperwork. And but the important part, I guess I should go to the top of my slide. The most important part is that we start intervening at diagnosis. We've been looking at this from the wrong side of the elephant. We wait until all the costs pile up, and then we're worried about, gosh, what do we do for that person? Instead of at diagnosis, with a sense of clinically what's coming, to try to expand health coverage and work with the patient to try to get wraparound support and coverage early on so that they stay on, following kind of doctor's orders, and that we prevent some of those bills from ever getting issued. So part of the problem in the navigation comes from that patients really need an advocate. You get these diagnoses. Number one, it's traumatic to get the diagnosis. There could be pre-existing stressors. There are people who start chemo right away. So there are things that can affect cognition and the ability for that person to be an advocate for themselves. And so that's why, kind of the special sauce is having the advocates involved, the navigators. Anyway, we start with an office. We get part of the paperwork, say, do you want help with out-of-pocket costs? And if people sign up, then we start working with them. But so I'm going to pass the baton to Debbie Broderick, who is one of our financial advocates. And Debbie, maybe, and we can go to the next slide, Val. But Debbie, it would be great if you could share a little bit about what it's like to work with these folks and what you encounter.
Thank you, Elise. When I have my initial call with the patient, I ask how they're feeling, how their treatment is going. Most of the time they're overwhelmed and stressed at getting a cancer diagnosis, facing treatments, and then the potential financial burden on their monthly budget. I have a current lady that I'm working with that she has a marketplace insurance plan with a large max out of pocket. When we took a closer look at her income, I realized that she could actually qualify for Medicaid, which then would eliminate her max out of pocket and her monthly insurance premiums. So she could get, and then if she's approved, she could also get her coverage backdated 3 months and get reimbursed for the max out of pocket amount that she has already spent on medical bills. Because of her cancer diagnosis, she could also qualify for Social Security disability insurance, which this would give her a monthly income and a little breathing room for her budget. In addition, we could also apply for a couple of local cancer nonprofits for their cash assistance. And if she did not get approved for Medicaid or decided she didn't want to switch to Medicaid because her doctor was not an in-network provider, we could look into getting her enrolled in a hospital discount care program, which would reduce or eliminate any outstanding bills We could also negotiate with providers to get her outstanding bills reduced or on a payment plan that makes it easier to manage on a monthly basis. We would also look at any other marketplace insurance plans that have a lower max out of pocket. I would also see if there are any funds available for insurance premium or copay assistance. And I always try and ask the patient if they or any of their household members have any other medical conditions that they take medication for. And then I can look to see if there are any grants open for those conditions that could help pay for their insurance premiums or medical payments. And if there's some of the medications, sometimes some of the chemo drugs they need to take are not covered by their insurance, I can look to see if there are any manufacturer programs that could help pay for those drugs. Many times the patients don't even realize that all of these resources are out there or that they could possibly qualify for them. So that's just an overview of what we try to do to help the patients that are struggling with the cost of cancer diagnosis.
So Debbie is a pure angel, and thank you so much for your work. Val, can we go to the next slide? So both of these, again, just kind of review some of the stuff that Debbie works with. And I guess I just want to make the point that, you know, when you go to the doctor's office, they ask for your insurance coverage, but of course they don't ask, are you in the right plan? Is there anything we can do on the front end to help you meet, you know, your max out of pocket? It's that nuance and that advocacy on the front end that can make a big difference. So what we wanted to make sure is that our people were getting this, our people meaning people that were struggling with, going to struggle with out-of-pocket costs, that they get the same care as anybody else. And so that equity piece was really important. But all these things were really hard for us to measure because we're not the hospital, we're not doing the billing, we're not seeing what's getting paid, we don't have access to, you know, bad debt numbers in the physician's office. And so I really love this program. We think we're making a big difference, but I had no idea how to get my arms around it. And that's when I heard about the work that CIVHC was doing for other nonprofits. And so I was able to reach out to them and say, hey, I've got a program, maybe you could help me figure out how to measure it and explain its impact. So that's how this whole partnership started. Sorry, I'm done, Val.
No, thank you.
That wasn't clear.
Trying to get to my unmute button. Thank you so much, Patrice and Debbie, for summarizing the program and what you all do with CGCA as well as the Carol's Wish program specifically. So now I'm going to get into the nitty-gritty details of what we actually did to answer this question. To Patrice's point, this kind of thing is very difficult to measure. And so we had to do a lot of background work to really think about, can we, and if so, what can we show using CIVHC data? And there were a lot of opportunities that we discussed, and I'll walk through some of those. So to get started with this process, we met with Patrice and her team to just take a step back and ground ourselves in what was Carol's Wish? You know, who was Carol? What was her story? And what is the mission and the importance of this program? And she already talked through much of that. And so then we took that a step further and said, okay, what might that look like in terms of outcomes for individuals? So there are a lot of things we can look at in the CIVHC claims data that can tell us about certain types of outcomes, the cost of care, et cetera. And we have a very specific patient population that has a very specific type of experience that may not show in our traditional ways of showing those kinds of outcomes. So what we did was we started in meetings with CGCA, and they brought in subject matter experts who were members of their board, including providers that they work with on a regular basis. And we had conversations to really understand what is the common patient experience for an individual who goes through diagnosis and treatment of a gynecologic cancer. And one thing we learned was that this is a type of cancer that tends to be diagnosed at a much later stage than other cancers. It's typically diagnosed in stage 3 or 4. So it's typically a more advanced disease. And so there's less variation in terms of if an individual proceeds with treatment. So we considered, what might substandard care mean? Could it mean they delay time to treatment? When we learned that most people either get treatment right away or forego treatment altogether. So we decided that maybe the timing of the treatment was not the right way to explore, do individuals going through this program get into treatment faster? We looked at, do they complete their treatment cycle on a shorter timeline? And we learned that the treatment cycle is pretty standard. If an individual is going through treatment, it's going to be about the same time. So we likely wouldn't see differences in our groups, things like that. So thinking about what we had available in claims and what is and is not applicable to specifically to gynecologic cancers. And I'll go more into detail on what we actually did. We also collected supplemental information from the program. So Carol's Wish sent us their program data, which included the participants with demographic information, but also their monetary assistance data. So every time they meet with an individual, what service is provided and what is the total value of the assistance they provided in terms of dollars saved for that participant. And then they also shared multiple case studies so we could read those and understand specifically what the supports are and how we might be able to look for those supports. They also shared our survey form. We considered potentially doing a multi-method evaluation, but we ultimately decided that incorporating the surveys would take us beyond the scope of just answering our basic questions. A brief note about the program monetary assistance data that helped us really narrow our focus on what to evaluate for this project. You can see, as Debbie and Patrice described in the overview, there are numerous ways this program supports patients, but far and away, the greatest monetary assistance that they provide is through that insurance optimization. So we knew we wanted to focus on total cost of care and member out-of-pocket proportions. So thinking about that financial toxicity with that insurance enrollment perspective. So knowing that, we operated on the theory of if an individual has optimal insurance, they will see lower out-of-pocket costs and are likely to be better able to access care and therefore have better outcomes as a result of reduced financial toxicity. So that was the theoretical framework with which we approached this project. And using the CIVHC data, we definitely have measures that we can track and look at to answer that question. So our focus for this project was saying, do program participants pay a lower member out-of-pocket proportion for healthcare than non-participants? So we just are looking at what's the total proportion they're paying out of pocket. The theory is lower out-of-pocket is lower financial toxicity. And we also wanted to incorporate as much as we could that question about equity. Is Carol's Wish successfully supporting individuals who are chronically under-resourced? To do that, we analyzed the total allowed amount as well as member out-of-pocket totals and percentage. So I'm just going to call out now, I use MOOP just to shorten the words on my slides. That's member out-of-pocket. So just remember that moving forward. We pulled those amounts that were associated with all medical claims, claims that were specifically for gynecologic cancer treatment, and pharmacy claims. And we pulled that from their diagnosis date through 6 months. And we looked at a time period of 2018 through 2022. And we looked at all of this information among Carol's Wish program participants, and then we developed a matched non-participant cohort. And I'll talk more about that in a minute. The data came from two sources, as I mentioned. So Carol's Wish provided the participant list and those program assistant records. We matched the program participant list to the COAPCD, and we pulled claims data and spending totals from the COAPCD. We also utilized the Johns Hopkins ACG system measures. So this is something that we have integrated into the COAPCD. And the Johns Hopkins ACG system, ACG stands for Adjusted Clinical Groups. This system is an industry standard. It generates a member level risk score using health diagnosis and care utilization from claims data over the previous year. The ACG groups are an industry standard grouping process. And so this is a research methodology that applies a developed algorithm to claims data to calculate scores of patient risk and characteristics. So using that ACG system measure, that allowed us to look at what was an individual's insurance before diagnosis. So we actually used that as a proxy for an individual's economic status prior to the diagnosis. So we presumed that an individual who had Medicaid before being diagnosed would indicate likely a lower income band. We also use the resource utilization bands, or RUB. So this is a score that is based on an individual's age, number of chronic conditions, and co-occurring diagnoses. And that is an estimate of how much care they're likely going to need in a given year. And so it's a way of controlling for an individual's likely total cost of care based on how sick they are. And lastly, we also looked at the social needs data. I won't be reporting on the social needs data just because it's based on claims, and specifically the Z codes that providers can use. And we just know that those are typically underreported by providers. So we didn't want to draw any conclusions based on those. But we did look at them and compare the populations just to get a sense of how well we're matching. So I'm going to briefly go through the results and focus most of the rest of my time on our discussion, because I think that's really where the meat is. So ultimately, our two cohorts, we matched the non-participant cohort to the Carol's Wish program participants. So we ultimately had 234 program participants in the Carol's Wish population. And so we matched those by drawing a random sample that proportionately was the same as the Carol's Wish program by resource utilization band, Medicare, Medicaid dual eligibility, and RUB. So that resource utilization band. So we wanted to make sure as much as we could that we were comparing apples to apples. So we said we're comparing patients who are kind of the same degree of unwell. They have similar rates of utilization in general. So we don't want to have that be a confounding factor in the results we see. And you can see that after selecting those groups, they were very similar in terms of insurance coverage prior to diagnosis date. But you can see that the Medicaid proportion of program participants was a bit higher, whereas the commercial proportion was higher for non-participants. So this kind of told us that, yes, the program is good at bringing in individuals who have lower incomes prior to their diagnosis. First, we ran t-tests, and I'm just going to breeze through these. So what we found was that for the total allowed amount or total spending from the diagnosis date through 6 months, Carol's Wish participants had a higher total cost of care or total spending on care. They also had a higher total dollar amount spent out of pocket, which makes sense. You have more care, you're paying more out of pocket. But what was very interesting to us is For gynecologic cancer specifically, the program participants had significantly higher costs of care for the gynecologic cancer claims, but their member out-of-pocket dollar amount was not significantly different than non-participants. So that kind of indicated to us, oh, there's something interesting happening here. And then when we looked at the total member out-of-pocket proportion, we did find that the Carol's Wish program participants had a significantly lower out-of-pocket proportion of the total cost that they were accountable for than non-participants. We also completed regression models because we wanted to really narrow down and control for factors such as the resource utilization band, the insurance type, things like that, and age group we also looked at. And so these are the regression results that are the estimated effects of the Carol's Wish program specifically. And you can see here that as a result of participating in the Carol's Wish program, the member out-of-pocket proportion was about 2.4 percentage points lower than for those who did not go through the program. When we narrow that down to gynecologic cancer claim spending, the member out-of-pocket proportion was about 3.8 percentage points lower. So a brief summary of everything I talked through just now, we saw that the total medical expenditures, both for all medical claims and those associated with gynecologic cancer, are higher for Carol's Wish program participants than they are for non-participants. The member out of pocket was still higher for program participants, but it was comparable between groups for gynecologic cancer claims. And despite these higher allowed amounts and totals, participants paid a lower percentage out of pocket than non-participants. We didn't see a significant difference in any of the costs for pharmacy claims, so we left those out of the remaining results. Based on our claims-based analysis and in conjunction with the supplemental information that we received from Carol's Wish, we believe this demonstrates a clear financial wellness benefit for participants. We're going to come back to that last statement in the discussion portion, but first I want to walk through, apologies, I got myself out of order. So one of the questions that we wanted to ask was, why are these total costs higher? And we brought these initial results back to Patrice and Carol's Wish program staff, and we said, okay, this is what we're seeing in the data. Does this ring true with what you see on a day-to-day basis in your program? And do you have any initial thoughts about what we're seeing? And their feedback was that, well, we get a lot of comments and reports from participants who say things like, well, I didn't really have great insurance before, so when I needed to go to the doctor, I just didn't because the copays were so high. Or, you know, now I actually even have insurance and can go and access care. We also have received comments from individuals who say, well, you helped me get into a plan that now covers my whole family, so now my whole family can access care. And so for us, that really kind of indicated that this insurance optimization piece was really an important part of the affordability question and the access question. So just having insurance doesn't equal access. Being able to afford the copays of your insurance, being able to afford the deductibles, et cetera, is a piece of that access and quality of care picture. So we thought that perhaps the higher spending that we saw might indicate that Carol's Wish participants were actually going to the doctor more than non-participants. But we couldn't conclude that based on just this analysis. There's a number of reasons those costs could be higher. It could be over a certain amount of years. We see annual inflation rates every year. It could be that somehow the two hospitals that treat program participants and the two hospitals where the program is not embedded have vastly different costs of care. There's numerous things that one could investigate, but we wanted to just ask the question, could the total higher amount and member out-of-pocket amounts reflect higher overall utilization, indicating increased access. And so we just went back and did a supplemental analysis and did a brief t-test comparing the average per member per period visits. So we just counted all of the visits and adjusted for insurance eligibility. And we did find that the Carol's Wish program participants did have significantly more visits within that period than non-participants. We also thought about, well, if it's only about copays and deductibles and cost of care, then one might expect that if you look specifically at members who have Medicaid, the rate would remain the same. But when we looked at claims that were billed to Medicaid, we still saw this increase. So that was interesting. It's worth investigating further. But we do believe at least a portion of this difference is attributable to having more access or using care more. Before we go into the discussion, I do want to kind of walk through some data challenges that we ran into and project solutions, and also just talk a little bit about the limitations, and then bring us back around to what this means and where we go from here. So first, you may have noticed on one of my earlier slides that I had diagnosis date in quotes. That's because there is no field in claims data that indicates a diagnosis. So there's not a diagnosis CPT code. There's not a date that says date this condition was first diagnosed, anything like that. The ACG system has the first year in which a condition was indicated. So we could use that, but we had some limitations that I'll talk about with that. So what we did is we used the ACG system to confirm the cancer diagnosis, because just because a diagnosis shows up once in somebody's claims does not necessarily mean they have that condition. It may indicate that they had a suspicious checkup and they wanted to do further tests and do a biopsy and confirm that that was the actual diagnosis. The ACG system, when it identifies individuals with that cancer diagnosis, they have the algorithm requires a certain minimum standard to confirm diagnosis. So for those who were identified in the ACG system, we went back to their CIVHC data and looked for the first date at which that diagnosis showed up as a claims diagnosis. And we went back an extra year prior to our analytic timeline to avoid capturing recurring cases, because individuals with recurring cases could have a different picture of total costs within that 6 months. So we wanted to make sure we were capturing first incidence of this case. And with feedback from CGCA, we thought that going back 1 year was adequate, because most people, if they have a recurrence, it will be within that year. We also, in our claims data, we don't have any income information, and we know that the socioeconomic status, such as social needs and race and ethnicity data, is lacking. And so, as I mentioned before, we used that Medicaid insurance prior to diagnosis as a proxy indicator of lower socioeconomic status. One limitation to the ACG system is it is an annual measure that's calculated, and it requires continuous eligibility. So we only get data in each year for an individual who had insurance for 11 out of those 12 months. So getting back to that question of folks who are underinsured or uninsured, it was difficult to capture them using this system. So one thing that we did was we extended our analytic timeline for capturing the system data, and we pulled the 3 previous years from that year of diagnosis, and we applied the most recent that was available in the APCD system, just to get as close to that individual's characteristic as we could. We also supplemented, we used a dual eligibility flag for our one-to-one matching. So participants were matched on their RUB, dual eligibility, and their age group. And so We were missing numerous dual eligibility flags. When we reviewed that data from the ACG system, it looked unrealistically low. So we supplemented that using our CIVHC eligibility data. We also had some issues with timing of enrollment in Carol's Wish. We had a few cases, by and large, the timing, the enrollment date for participants in Carol's Wish was shortly after the diagnosis date. There were a few cases where it was shortly before, and there were also a few cases in which it was after that individual's 6-month time frame. So we would need to dig deeper into that. We actually did not adjust anything for that because it was such a small number of individuals. Some limitations to doing the project using the CIVHC data, or the project overall. First of all, we had a small sample size. So we had a 63% match to the CIVHC. So when we received the program participant list from CGCA, we were able to find 63% of those people. However, when we then applied the inclusion criteria using the ACG system data, we lost more individuals. And part of the reason for that is the ACG system only captures 3 of the 5 gynecologic cancer types. So we actually had to narrow our pool of participants to only those with 3 specific types. The findings from this project, we're confident speak to the value of the Carol's Wish program, but because we can't really speak to who wasn't included in this project and what their characteristics were and what their trends were, these findings are not generalizable across the board. So this is a specific evaluation of the Carol's Wish program. And it was also difficult to capture the full extent of insurance optimization impact. So we don't have information in the CIVHC for uninsured individuals or health plan types that are not included. So the CIVHC does capture about 75% of the population of the state of Colorado. So we have most individuals, but we are missing things like TRICARE data, VA data, ERISA covered plans, and uninsured individuals. And as I mentioned before, the demographic information is very limited. Opportunities that we saw to kind of grow beyond this project included, we weren't really able to attribute changes that we saw to any specific behavior or type of assistance or anything like that. So we could further explore that, including looking at those utilization trends. Do we see patterns in what types of care people are getting when they go through the Carol's Wish program versus others? We did not, as part of this project, assess an individual's choice to continue with cancer treatment. So we ultimately decided not to go that route as we thought it would be more valuable to focus on the costs of care. But one question might be, do higher costs that we see in this analysis reflect an increased likelihood of cancer treatment specifically? So that's an opportunity to dig a bit further and go that way. We could also do a qualitative analysis to add more of the story to the data that we're seeing and get some of that additional context for what we're seeing in these results. And then we can also even look at, we didn't do a pre-post evaluation looking at what were members' insurance enrollment prior to enrollment in Carol's Wish versus after. So that would be another way to look at this data. So now I want to just refocus us on the results of this analysis so that we can launch into the questions and discussion. So just to bring it back, we found that Carol's Wish program participants had both higher spending and with a supplemental check, it appears they have higher utilization rates in the time between diagnosis and 6 months. And this trend held for Medicaid members specifically. We do believe that the Carol's Wish program is addressing needs specifically for Coloradans who are chronically under-resourced. So before we did our population match, the program participants had more reported social needs. Again, that doesn't mean the others did not have those needs. It's just that they were not reported. And also those individuals were more likely to have Medicaid insurance. So for us, that was more an indicator. We captured a lower income population with the Carol's Wish program. Along with the staff and participant feedback, the enrollment and optimization services help families access care. The supplemental financial supports help the program participants bridge additional costs and manage payments while waiting for enrollment windows. And through conversations with the staff and through reading the case studies that were provided, it does appear that there is a reduced burden of finance-based decision-making. And again, this is one of those things that's very difficult to quantify, but there is that anecdotal response that a lot of patients, after going through this program, have to make fewer hard decisions between treatment and something else. So that may be sending a kid to college, keeping her home, etc. And so reducing that financial toxicity that we believe we're seeing in this data can have a broader impact that we're just not really able to quantitatively measure in this analysis. So now we can launch into the discussion of what's next. So our hope is that CGCA is able to leverage these results to sustain and expand, and that the results of this evaluation actually answered their question. And we plan to continue discussing these additional opportunities and brainstorm ways to dig a little deeper using the data sources that we have or potentially bringing in more. So as we transition into the questions, I think I want to just start off with Patrice, like for you and your program, I'm curious what these results have meant to you as you and your team and your board digest them, and kind of what your next steps and thoughts and questions are.
Well, I will start by saying we are still digesting them, but it was not at all what I was expecting to see. And it was more than we were hoping in some ways, right? The number one thing we wanted was for people to have same access to care and it was important for us that the people that were enrolled with the program had at least the same level of care. We didn't want it to be shown that they were accessing less. We wanted it to be shown that they were accessing the same amount of care so that this would be an equity bridge. But then to find out that they had accessed just more healthcare in general, I think was like a bonus on top of it all, that understanding your health coverage and feeling confident about using it without endangering your family's finances is what we believe we're seeing. Now, as Val said, there are several questions that you could ask about the data, but that's what I believe that the navigation shows. And so we're delighted with that. Now we have to figure out who's interested in hearing about about that what we're doing is that people are accessing more care, spending more percentage less, but getting more care. So it was a surprise, and I am not sure what next steps mean, but it was not what I was expecting. So grateful to Civic for working with us, try to figure out how to get our arms around this. Like Val said, there's just a lot that you can't even measure. Like the people that obviously in the database, it doesn't say this person had no insurance before we started working with them, or, it just started, obviously the claims are recorded on the plan that we measured. So some of that is hard to capture, is all.
For sure. Thank you for that. I'm curious if other folks on the call have any additional questions or reflections?
I'll also add that, you know, to me, it's also a real plug for navigation, right? Expert insurance navigation, because people just come into settings with what they have. They don't know, and I sure didn't know before this program that your situation could be made better. So working with people on that, I think, is a real opportunity.
Mm-hmm. I think that's a really important point. Both the expert navigation in terms of people just don't know about these resources and these nuanced details. And, you know, thinking about myself when the insurance enrollment period comes around, it's so stressful to figure out and guess, what are my costs going to be? What insurance plan do I enroll in? What choice am I making? Is it the right choice? Am I going to be able to afford my care, et cetera? And that alone is a stressful process. And I can only imagine what that feels like when you've just received a cancer diagnosis and now you have to go through that whole process again with a totally new lens that is emotionally overwhelming.
What was Carol's wish was a question in the, so Carol's wish was that people would have access to care, equal access to care regardless of socioeconomic situation.
Yeah, and I'm happy to, shamelessly copied it directly from your website. So there's the summary of that. So the Carol's Wish program is a financial navigation program to help individuals who have received a gynecologic cancer diagnosis access financial resources to reduce financial toxicity associated with a cancer diagnosis. I agree with you, Dave. The limitation of the ACG system, it is an incredibly robust and highly accurate system, and it's challenging because it does require continuous eligibility, which is a huge equity. Like when we're integrating equity into our analyses, that's a big limitation because we know that individuals who are facing continuous health inequities often have non-continuous coverage, if any at all. James, just to respond to your question, which was just clarifying the higher utilization. So Carol's Wish program participants, yes, they had higher utilization rates. The percent of the member out-of-pocket cost was lower, but the member out-of-pocket spending, like the total dollars paid, was higher overall for medical claims. For claims associated with gynecologic cancer, there was no significant difference for Carol's Wish participants. So yeah, it is a bit of a conundrum in terms of thinking of they had higher costs out of pocket. So how could that reduce financial toxicity? But one thing to consider also is that piece is where the additional financial navigation services come in terms of enrolling for government programs and grants, nonprofit grants, and other funding sources to help individuals cover those increased out-of-pocket costs that are associated with treatment as well.
And they access a lot more care.
Yeah.
It costs a little bit more, so that overall percentage, but percentage-wise, they got a lot more care.
Yeah. So they're spending more, but they get a lot more for what they spent. Yeah. There was a question above that was answered in the chat regarding looking at outcomes. We did have several discussions in the beginning of whether looking at patient outcomes might be a good way to assess this question of substandard medical care. And we ultimately determined that using the CIVHC data, typically in terms of health outcomes, we look at ED visits or consistency with prescription fulfillment or inpatient visits or rehospitalizations or things like that. But specifically for gynecologic cancers, because they tend to occur in a slightly older population and tend to be diagnosed at a later stage. And Patrice, feel free to correct me if I misspeak here, but our understanding was this tends to be a cancer with a relatively high mortality rate because of the lateness of the diagnosis. And so regardless of what that individual's ultimate outcomes are, we didn't think we didn't know that we would be able to capture a reasonable enough difference in the typical things we look at in terms of outcomes in claims data that would look that different between the groups just because of the severity of this kind of diagnosis typically. And so, you know, that is something that if we can think of a way or some sort of measure that would be found in claims data, or if we can, you know, pair that with some other data source, such as like vital statistics, death records, that kind of thing, that could be a future evaluation, but we didn't quite see a way to do it within the scope of this project. And so we really focused on that access to care and financial toxicity question that really focused on the insurance optimization side. And thank you for clarifying in the comments, Darcy, that the continuous insurance is a limitation with the ACG, but just to clarify, if somebody changes insurance, that is perfectly fine. That's still captured in the ACG. It's just if they lack coverage for more than 1 month in the year. Well, Patrice and Debbie, I want to thank you again for partnering with us for this project and for joining us for this presentation. I'm really excited to see where you go from here. So,
Thank you to Civic. I had an impossible problem that you helped me figure out, and it was so terrific working with all of you. I'm very grateful.